So my name's Taylor Justice. I am the president and co-founder here at Unite Us, and today we're going to talk about how we connect health and social care. So Unite Us was founded back in 2013, initially focused on the veteran and military population. Myself and my fellow co-founder both served. And we saw a need to move away from resource directories where you're just sending referrals out into the community and really focus a solution around outcomes. And we quickly started to build networks across the country and realized that the challenges that the veteran and military community face are not unique. They just happen to be the perfect petri dish of American society when you look at age, race, socioeconomic status. So in 2015-16, when social determinants of health started to become a big buzz term within the market, we saw an opportunity to provide a solution to everyone, where we became service provider and population agnostic and started to build infrastructure across the country, where regardless of health, human, social service entities, regardless of population, if organizations needed to coordinate care around a shared client, we could provide a solution for them. And so we see ourselves as the operating system for social care. And I often talk about, when I think of social determinants of health and the market itself, you have, I always say that we're in phase 0 of 30 of social determinants of health, and maybe 30 is the wrong number, maybe it's 1,000. But the reason I say phase 0 is because most communities lack appropriate public health infrastructure, meaning healthcare doesn't have a seamless way to communicate with community-based organizations, and community-based organizations, public health entities, don't always have an efficient way to communicate back into healthcare. And so we wanted to bridge that gap with our main product that we call Unite Us Platform, that is a solution that creates a supply chain. It eliminates barriers to access. It brings human and social service providers to the same priority level as healthcare, and that we can connect all of these historically siloed and fragmented entities into a common ecosystem to track outcomes together. And when you connect all of those nodes, you can then get the insights, not only on the process and the supply chain itself, but then also layering in predictive analytics to get ahead of problems where we aren't just reactive, we're being proactive in our engagement with individuals as they enter our organizations. And then we see the market moving to value-based social care contracting and creating a marketplace where community-based organizations are reimbursed for the services that they provide, where their revenue streams don't have to be dependent upon grants or philanthropic investment. They can create a solution for the services that they already provide today that's a benefit to healthcare, that's a benefit to government. And when you layer these solutions on top of each other into an ecosystem, you then start to see systematic transformation across the market. And so we continue to scale our solution so that we can look at individual journeys and then aggregate those across the community and analyze what's happening. So the Unite Us platform is really broken down into 2 major components. There's obviously the technology, and think of our technology as the mesh between systems of record. So we're not going to replace an electronic health record, just like we aren't going to replace a care management platform. And if you have a sophisticated community-based organization that has a technology platform that they leverage, again, as their system of record, you're not going to replace that. But you have to integrate, you have to embed yourself into the workflow, and you have to create value for every organization that participates. So you connect all of these nodes together so that you can start to track timeliness. How long does it take organization A to make a referral to organization B? How long does it take organization B to accept control of that referral? How long does it take organization B to close out that case? And so the technology is super important, where you have organizations, again, that it have historically been siloed and fragmented, haven't had the ability to communicate with each other outside of phone calls and emails. You have to have infrastructure that is HIPAA compliant, FIPS, FERPA, 42 CFR Part 2. You pick your security acronym. But at the end of the day, technology is a piece of the puzzle. You have to also layer that with our customer success team on the ground. So we've realized since the very beginning of our work that if you don't create value for a health system or a health plan, i.e. integrations and whatnot, they're not going to work with you. But you also have to take that same approach with community. And so since we've cut our teeth in the very early days, focused on these community-based organizations, we understand how to create value for them, how to help them operate more efficiently. Most community-based organizations won't have a technology company come in and help them become operationally efficient. So our team on the ground are individuals that we hire from the communities with which they live. They understand the dynamics of their communities, and they're for the life of our contracts. You can't just throw technology at a community and expect them to use it, because once the adrenaline of a new technology tool fades away, if it's not properly seeded, usability is going to fall off a cliff. But when you do that appropriately, now you have the ability to monitor journeys of individuals. And when we talk to health systems and plans and others, attributing an intervention to an individual that drove a cost reduction or an improvement in that person's health is often hard to calculate. It's even harder to calculate in the human and social service landscape if you don't have that infrastructure established. So when COVID-19 hit, we saw a need where around 46% of organizations, community-based organizations, either limited their services or suspended services altogether. So working off of a resource directory and just shooting people out into the community, you had the potential to send somebody to an organization that wasn't open or didn't have capacity. So you need to make sure that you have a coordinated network of organizations that are not only open, but also have capacity to provide those services. So this example here of a Medicaid member that was previously incarcerated, they tested positive for COVID-19 and were subsequently released. And so they had a number of different needs that needed to be addressed within a very short window. And so this individual didn't have stable housing. And so we needed to not only take care of the housing need, we needed to connect them to a primary care provider. We needed to provide basic housing supplies once we addressed that need, medical equipment, and then also transportation. And this isn't about addressing just the needs that are presented day one. These needs continue to compound, and what we want to show is an overall positive trajectory on an individual's health and well-being. So when you look at the beyond category, now what's next? You have them stable, you have them connected to care, you have them in housing. Now we're looking at connecting them to local Department of Labor or workforce agencies and getting them onto a path of self-sustainability. And now we want to talk about care. So from a scaling perspective, we mentioned earlier that Unitas is across 35 states. And in North Carolina, our work there is under the tag of NC Care 360, where we're the technology platform in partnership with the Foundation for Health Leadership and Innovation, the United Way of North Carolina 211, and Expound. And as part of our statewide infrastructure, we are connecting health systems, health plans, government entities, and community-based organizations across all 100 counties. Within our first 2 years, we had to have our network deployed across the entire state. So in 2019, we completed our first full year where we had 50 counties live on the platform. And then in 2020, we had another full year to bring on the remaining 50 counties. But as we all know, COVID-19 hit, and we had to alter our plan. And we were able to launch the remaining 50 counties 7 months early and do that virtually and do it within a shorter time horizon because the needs were significant and organizations were raising their hands saying, we need assistance handling not only the volume, but handling those capacity issues as well. So when we talk about the Unitas platform, you have to properly seed and bring these community-based organizations to the table, create that value, and move quickly to ensure that you can meet our true north here at Unitas of proving is the individual receiving the services that they need, not just making a referral or that they have a need, but actually receiving that care. And then we look at our partnership with Kaiser Permanente, where we're scaling our solution across their entire enterprise, including 8 states and the District of Columbia. Now, Kaiser Permanente has only purchased 2 enterprise-wide software solutions. One was Epic, their electronic health record, and the second was Unitas. The beauty of the relationship with Kaiser Permanente is they are making this available not only to their 12.3 million members, they're also making it available to the 68 million people that live within the communities that they serve. So this isn't just a Kaiser Permanente specific network. They're inviting their historic competitors to join on this network because, like us, Kaiser Permanente believes that organizations, healthcare, health plans shouldn't be competing on connecting to community-based organizations, but should be competing on how they provide those services to their patients, their members, their clients. And so the ability to scale this infrastructure is super important. But then you have the insights that sit on top of the infrastructure once built. So we talked a little bit about the process metrics of network partner activity, service demand, delivery, where are gaps in services, are organizations running into capacity where I need to throttle back or throttle up the number of referrals an organization might need to receive. But when we get into the data, specifically on the Medicaid population, we're seeing people coming in with more than 2 needs that need to be addressed at a given time. So what are the co-occurring needs, but also what are the reoccurring needs that individuals are facing so that we can optimize a network to fill those gaps and make sure that they access care quickly and get resolutions quickly. And then we're also monitoring that network efficiency. Can we optimize how long it takes somebody to connect to their best fit provider within a community? Can we optimize how quickly an organization can accept a referral? And can we help them optimize how long it takes them to deliver that service? Now, we know a legal case is going to take much longer than food insecurity, but we're monitoring each of those supply chains in real time so that we can adjust on the fly and move that community to optimization. Now, we made our first acquisition earlier this year of Staple Health, a Vermont-based company that does predictive analytics and modeling. And the beauty of the predictive modeling is there's a lot of organizations in the community or a lot of technology companies that are pulling publicly available data, doing certain risk scoring, or coming up with particular models of care. What they miss is the outcome data that we're able to provide through the Unitas platform. Now, you marry public available data with the outcome data that we see on the ground, you have a greater opportunity of having a very accurate risk score, a very accurate way of predicting social needs, but also engagement risk as well. Based on the information that we're seeing, is this person at risk of potentially being lost to a referral, where we then need to think about how many touch points we have with the individual so that we can get them connected to the right service within a timely manner. All of this drives towards having appropriate outcome reporting that's managed part of the core Unitas product, but giving valuable insights that help people make better decisions based on what is happening real time. And then finally, we want to talk about Unitas payments. So this is a solution to buy health at scale. So this is the first product to contract, invoice, and pay for social care. And this really stems from our work in North Carolina, upstate New York, some innovation that's happening in California and in Utah, where healthcare organizations, government entities want to buy health. I think that was mentioned in the panel earlier. And facilitating a marketplace where if you're bringing human and social service providers to the same priority level as healthcare, it's also creating a business relationship between those organizations. And how do you transact those social interventions? So think of removing moldy carpet from someone's home and replacing it with fresh carpet, medically tailored meals, ride-enabled referrals through Lyft or other transportation providers. There's a technology component to facilitate that transaction. When you look at community-based organizations that historically don't have appropriate back office infrastructure to submit an invoice, i.e. a claim to a plan or government system, we've created a lightweight revenue cycle management that plugs into traditional healthcare revenue cycle management to facilitate that transaction. But then there's also the social care program design, the value-based contracting models where health systems, health plans, state governments don't have to contract with thousands of different organizations. We create that governance structure, that governance support to ensure that we are helping these community-based organizations create additional revenue streams to facilitate and have capacity to provide their services, not just relying on them to take care of our members or patients without including them in that business relationship. And so when you start to think about the Unitas platform, from building the infrastructure, analyzing the insights, being predictive, and now adding Unite Us payments where you're looking at the performance models and creating very targeted interventions to improve health, not just healthcare. You have a very, very powerful solution for communities, for states, for regions, and we have a very aggressive plan of anybody that falls under the category of health, human, social service. We want to touch, engage, or right across Unite Us nationally within the next 5 years. And so we have 35 states that are currently through a statewide rollout of our implementation, and we want to continue down that path so that, again, we're helping not only our community-based organizations, we're helping the individuals that need care, we're helping healthcare organizations all operate within a common infrastructure where we're all working together, whereas previously we were working within our own silos. So with that, I will pause and take any questions. Thank you.
Thanks, Taylor. So I just want to throw out one quick question as we're wrapping up, and that is just, you alluded to the really expansive, sort of the breadth of your work in terms of the number of states that are actively using Unite Us. And I'm curious if you could say a little bit more with regard to how you're actually building out your own network of Unite Us users across states, because I think that's a unique sort of aspect of the work that you're doing. So any opportunities, any sort of key learnings that you've been able to distill that are, you know, that are relevant and versatile across states and across plans and such? You could say about
yeah, I mean, I think that's the one thing that separated us from the pack, and it's kind of been our secret sauce since day one. And I think it starts because we started off in the community, focused on the community. I think our process that we went through was built off of personal pain points. I think our first network that we ever launched back in 2013, 2014 took us 18 months because we had no idea what we were doing. And when you're dealing with community organizations, you're dealing with individuals that are very passionate about the work that they provide. They're very guarded of the patients, members, clients that they serve. And so when someone new comes in and says, hey, here's a technology platform, or here's a different way of approaching this, you have to take them through a change management process. So we've implemented a change management implementation strategy. That's why we invest heavily in putting people in the communities with which they live, hiring people from the communities with which they live, and that's why they're there for the life of our contracts. And we take them through a systematic process that has weekly KPIs before we ever turn on technology, so that we seed that value, that that the community is part of the building process, not just health systems and health plans, but the community is at the table kind of driving the governance structure. And before we ever go live with technology, we're taking them through that process. We've seen a lot of success with that model because, again, while we are a technology company, technology is just a piece of this puzzle. This is about humans, and it's very hard to reinvent health, human, and social services by eliminating those humans, and that's why we value it so high.
Great. Well, thank you so much for your presentation and for your insights. We're nearing the end of the session today, so I really just want to thank all of our panelists as well as our presenters for a really rich discussion today.